Welcome to Chapter 44, and this is Chapter 44, Part 1. This presentation will cover seizures and Parkinson's for the most part. Seizure is a sudden, excessive, synchronous electrical discharge within the brain. The electrical discharge occurs within the neurons within the brain. And just a review for the neurons, just to make sure we have an understanding, because as we go forward talking about other neurological disorders, we really need to have a somewhat of an understanding of the neuron. The neuron is a basic unit of the nervous system. Its important job is to transmit impulses and messages. There are two different neurons. The first one is a motor neuron, or it's also called an efferent. Efferent is with an E. The efferent impulses travel from the central nervous system to the peripheral nervous system. The other type of a neuron is a sensory neuron, or afferent with an A. It's A-F-F-E-R-E-N-T. The sensory neurons, the impulses travel from the peripheral nervous system back to the central nervous system. So basically it carries its impulses, and the neurons all have to be working properly in order for this impulse travel to take place. So when seizures occur continuously or repetitively, they're then called epilepsy. There are essentially three different classes of seizures. You have a general seizure, partial seizures, or there's seizures that are unclassified. Generalized seizures consist of tonic-clonic seizures. Tonic is the stiff, rigid muscles of the arms and the legs typically. The clonic portion of a generalized seizure is the rhythmic jerking of an extremity. Another type of seizure that falls under the generalized seizure is an absence seizure, and this is more common in kids, and they also tend to run in families. Basically, an absence seizure is just where the patient has a brief episode of like a loss of consciousness. They'll appear to be daydreaming or have a blank stare on their face or just sort of zone out, and it's very brief. That's referred to as an absence seizure. Partial seizures are referring to, there's a simple partial seizure or more complex partial seizure. More complex partial seizure is a seizure where the patient will black out for 1 to 3 minutes. The simple partial seizure is a seizure where the patient actually remains conscious, and it's more of like an aura. They have sort of the feeling, sort of like a deja vu type feeling. That's a simple partial seizure. An unclassified seizure is just the symptoms do not fit any other category. And truly the diagnosis of seizure can be essentially very challenging. Types of seizures are even further broken down into a primary and secondary. Primary seizures, again, if they're repetitive, are referred to as epilepsy. The primary seizures are found to not be related to any identifiable cause. Secondary, and that's in contrast to the secondary seizures. Secondary seizures, there is an underlying cause, an underlying reason. Some of those underlying reasons can be alcohol withdrawal, a metabolic issue, a head injury, heart disease at times can be referred to. There's multiple reasons, and I believe those are all on the next slide. So these are all identifiable reasons for a secondary type of a seizure. Treatment for a secondary seizure is usually the removal of the underlying cause. If it is perhaps an electrolyte disturbance, if those can be treated. Alcohol withdrawal, if they can treat the withdrawal symptoms, perhaps they can decrease the incidence of seizures. If it's substance abuse, if there is a recreational drug that is causing the seizures, then hopefully we can remove that. The patient will quit taking that, and then that hopefully would decrease the incidence of the seizure activity. So a really important thing for a nurse to be aware of when taking care of a patient who has any type of a known seizure activity, any kind of a seizure history, is making sure that they are prepared to provide safety, a safe environment for a patient with seizure. Seizure precautions are of utmost importance. Probably two of the main things that you need in the room for a patient when you hear that you're getting a patient with a history of seizures is the oxygen and the suction equipment. You need to have that in the room and and it's ready to go in case a patient would seize, so that you're not running around looking for this stuff when the seizure actually happens. You want to be prepared to protect their airway. It's really important that they have IV access if at all possible, and hopefully if it's a patient in the hospital, they already have IV access. Side rails up. Side rails up currently is a little bit debatable. We don't use side rails like we used to. It used to be everybody had side rails up, but now it's more of a safety thing. So that would just be patient specific. If there's side rails up, they typically pad them so to protect the patient's safety. So if they do seize, especially if they have the tonic-clonic seizures, you want to make sure that they are not, they're padded. The side rails are padded so that they don't hit their head on them. No tongue blades. We used to keep tongue blades at the bedside. No longer is that an option. They found that it causes more harm than good. So really the biggest thing is to make sure that you have the oxygen and suction equipment prepared to protect that patient's airway at all times. The other thing the nurse needs to do is make sure they just monitor for any seizure activity. If seizure activity is identified, a big job of the nurse is to note the time that it started, how long it lasted, what kind of a seizure. Was it an absence seizure? Was it a tonic-clonic seizure? Was it a partial seizure? Just making sure that they take note of how long it happened and exactly what the body movement was. Just kind of referring back to the generalized seizures, they typically involve both hemispheres of the brain. And they manifest by symptoms that affect the entire body. So that is typically your tonic-clonic. Those are your grand mal seizures. You may have heard that term before. 90% of seizures are grand mal seizures. So since 90% of seizure activity is a grand mal seizure, you want to make sure that you're prepared to take care of that patient. Again, nursing interventions for a patient who is seizing, just make sure, it really does depend on the type of seizure. If it's an absence seizure, of course, the interventions aren't near as intense as like with a grand mal seizure. Observation and documentation, again, are very important. Patient safety, just making sure that you're keeping them safe. A lot of times they like for you to kind of lay them over on their side if possible, especially afterwards. Just to make sure, because that helps maintain their airway. Do not restrain them. Don't try to hold them down. Just kind of be there to support them and keep them safe. Okay, for non-surgical management of seizures, secondary seizures, again, like I said, you want to remove the underlying cause, and typically that should take care of your seizure activity. In your primary patients, with the primary seizures, anti-epileptic medication is required. Typically, it takes more than one of a drug regimen to control the seizure activity. They usually add one at a time until seizure control is achieved. Many of these drugs, they have to have blood levels to ensure that they have a therapeutic blood level. So teaching them to make sure that they're compliant with getting their labs and taking their medication is very, very important with these patients. This is a list of medication that's pretty common drugs for anti-seizure medication. Phenytoin, or it's actually Dilantin, is what is the drug name or the brand name for phenytoin. It's a pretty common drug. Real important thing with phenytoin is that it should not be given with Coumadin or warfarin. Those two will potentiate the side effects of each other. So someone who is on warfarin should be on a different drug for anti-seizure medication. All of them require that there is labs drawn to make sure that they have a therapeutic level. They need to make sure that they are taking them, and they need to take them as ordered. It's not something that, again, like if they quit having seizures, that they can quit taking. Especially if they have like a primary epilepsy, they need to take this forever because they need to prevent their seizure activity. You may have seen some of these meds in other areas, especially your gabapentin. That's another. Some of these drugs are used in other areas, so they are appropriate for that. So you might be familiar with these from. I know the gabapentin is typically used for like a diabetic neuropathy. Tegretol is also, which is the carbamazepine. Is a Tegretol, which has been known to be used for antidepressant and antipsychotic medicine as well. So you will see these in other areas as well. Page 934 in your book, it's chart 44.3 is a great table that goes through all these medication. Talks about when it's appropriate to use them, what types of seizures they are most helpful in. So make sure you review that chart. So the meds on the last slide reviewed preventive medication. So those are anti-epileptic medications. They are used to prevent seizures. This list of medication is used in the event of an acute seizure. So if a patient is having a seizure that is lasting more than 3 to 5 minutes, these medications will be administered via IV to stop the seizure. So these are meds utilized to stop a seizure. It's very important that a seizure be stopped, especially if it's lasting very long. The longer a seizure occurs, especially if it's a grand mal seizure, the patient could have complications from a seizure that lasts too long. So we will administer the lorazepam or diazepam IV to stop the seizure. Again, you see phenytoin again. Phenytoin can be given in the event of acute seizure as well. A loading dose will typically be administered, and then they will be put on a management regimen of the phenytoin. Okay, status epilepticus is a medical emergency. This is when the seizures last more than 5 minutes, or the patient keeps having repeated seizures over and over again. And like I said in the last slide, when this happens, when a seizure lasts for a prolonged period of time, the patient is at risk for complications such as neurological damage. Because typically when somebody has a grand mal seizure, especially when it's prolonged, it can actually maybe impair their airway. They're not getting usually enough oxygen to their brain, and they can actually end up with with a brain injury from a hypoxic brain injury from a prolonged seizure. So, like I said, this is a medical emergency. This is when we administer the IV medication, such as lorazepam or diazepam, to stop the seizure activity. It needs to be done so that the patient does not experience any kind of a neurodeficit as a complication from prolonged seizure activity. So again, just a review of the drug therapy for the prevention of seizures. Blood levels have to be monitored to make sure that the level, everybody metabolizes these drugs differently, so you got to make sure that that they have therapeutic levels so that it is effective in stopping their seizure activity or preventing it. There are some drug-to-drug and drug-to-food interactions. Like I said, the phenytoin should not be given with a patient that's on warfarin. There's some drug-to-food interactions with some of them. I believe it's a lot of maybe some grapefruit. Some of them with citrus foods, it interacts with them. So just be aware of that. And just make sure that you educate your patient regarding getting their labs, taking their meds as ordered, and not just stopping them because they feel better. They still need to continue to take them. A patient with seizure activity can really experience some life changes. they need to have their seizure activity controlled with their anti-epileptic medication. If it's well controlled and if they're very compliant with their treatment, then they can pretty much function as a typical human being. However, sometimes it does if their seizure activity is not controlled. If they're not a doctor doesn't release them, they can't drive. Sometimes they can't operate some machinery. There's certain occupations that they may not have if their seizure activity is not controlled. So something to take into consideration. Sometimes they need support groups. And they need to, just be aware of all their resources they can have and be able to utilize that so that they can be productive and continue with the jobs, with the normal life that they had. But a lot of it is compliance with their meds. There is some surgical management that can be performed in the patient who maybe is having difficulty having seizure control with medication. Maybe the medicine is just not working for them. So there's several listed here that could happen. Vagal nerve stimulation is becoming more and more popular. It's basically where they sort of insert a little vagal nerve stimulator in the patient's chest, and when the patient feels as if a seizure is coming on, they can actually activate it, and it can stop the seizure right there. So that's been a pretty popular one lately because it's been pretty workable for most patients. It's pretty easy to do. Your other surgeries are a little bit more they're a little bit more invasive, so they're a little bit bigger surgeries, and typically they will not do those surgeries unless the patient really is pretty desperate and is really having difficulty in controlling their seizures. But for the most part, seizure activity is controlled with medication, and sometimes the vagal nerve stimulator may be an option as well. All right, so let's talk about Parkinson disease. Parkinson disease is a progressive neurodegenerative disease. It's a debilitating disease. Typically happens in older adults. If you look through the pathophysiology of Parkinson's disease, what ultimately happens is the loss of dopamine, which is a neurotransmitter. The loss of this neurotransmitter results in the loss of the ability to refine motor voluntary movement. The exact cause of Parkinson's disease is unknown. It does tend to increase with age. There are 4 cardinal symptoms of Parkinson's disease. These consist of a tremor, bradykinesia, which is also known as the slowed movement or no movement, which is akinesia. The third thing is rigidity, so it's rigid muscles, rigid arms, rigid extremities, and then postural instability. It's estimated about 10% of cases of Parkinson's disease is not actually Parkinson's, but it's a Parkinson-like motor activity caused by some medications. These medications could be some antipsychotic meds, some antidepressants, the SSRIs, or lithium, can mimic the signs and symptoms of Parkinson's. So it's real important to monitor to determine if a patient has been on those medications. You have some great charts in your book on page 942. Takes you through the stages of Parkinson's disease. It's separated into stages according to the symptoms and the degree of disability. Starting from stage 1 is mild, and moving up to stage 5 where the patient is completely dependent on someone for ADLs. There's been some research lately. Like I said, the exact known cause is not known at this time of Parkinson's disease, but they're finding that there might be some, exposure to pesticides, herbicides, some kind of chemicals that potentially puts a person more at risk. There's a lot of research going on out there right now. Thankfully, to some of our celebrities that have been diagnosed with Parkinson's disease. There's a Parkinson Foundation website that provides a lot of information. If you would like to look that up, it actually has a lot of great information on the latest and greatest out there on Parkinson disease right now. Chart 4410 on page 942 is a great chart that talks about all the signs and symptoms related to Parkinson disease. The important thing to notice is a lot of it is that shuffling gait. That's a real common signs and symptom of Parkinson disease. The other thing to note is the fact that there are some psychosocial symptoms related as far as depression, rapid mood swings, some dementia and sleep disturbances that are also related. So it's not just physical symptoms, but also the psychosocial symptoms as well. Another very important chart to look at in your book is chart 4411. It's on 943. Discusses the care of the patient with Parkinson disease. So those are important interventions for a nurse to be aware of in taking care of a patient with Parkinson. It's allowing more time, making sure that their medications are on time, and being a supportive, assessing them for those psychosocial signs and symptoms, etc. So make sure you look that chart over. So treatment for Parkinson disease revolves around reversing the symptoms and enhancing dopaminergic activity. So like I said, the pathophysiology is that the fact that neurotransmitter dopamine does not work. It's not active. So the treatment revolves around making sure that we do something to mimic the action of that neurotransmitter dopamine. Levodopa, carbidopa has been pretty much the hallmark of treatment for Parkinson. Levodopa is an immediate precursor of dopamine. However, levodopa cannot cross the blood-brain barrier to be converted to dopamine. So typically what they do is they add the carbidopa. The carbidopa is included in the formulation, and it's levodopa and carbidopa together is referred to as a drug called Sinemet. That's the combination of levodopa and carbidopa. So levodopa, like I said, is a precursor of dopamine. It actually does cross the blood-brain barrier and is converted to dopamine in the brain. So that's the job of the levodopa portion of it. It does cross the blood-brain barrier and it's converted to dopamine in the brain. Carbidopa is a supportive drug, and basically it prevents that conversion of levodopa to dopamine outside of the brain. So it's sort of a controlling portion of the Sinemet. So levodopa has been known to be the most effective therapy for Parkinson's disease as to date. So these drugs are pretty interesting, these Parkinson disease meds. Typically what happens is a patient is well controlled in the first 3 to 5 years with these drugs. But they will actually build up sort of a tolerance to them. They start having times where the drug wears off. So then they typically have to kind of start working with like the immediate release and a sustained release formulation of the drug to try to keep that level so that they don't have that wearing off time where those symptoms will reoccur of the Parkinson's disease. There are pretty significant adverse effects of these meds. They usually consist of a postural hypotension, nausea and vomiting. It can sedate them a little bit, can give them vivid dreams, and dyskinesias. Dyskinesias are like this, kind of like the lip smacking, hand rolling dyskinesias, and it's sort of similar to the dyskinesias that patients can get with antipsychotic meds. Anticholinergic drugs are also medications that are pretty effective. They help alleviate the symptoms of Parkinson's disease. They decrease the cholinergic activity, and that in turn will increase the dopaminergic activity, which again, like is our goal, to get that dopamine to work. They're usually most beneficial for mild symptoms, especially the tremor but they typically have to be used with another drug. Cogentin is the most common anticholinergic drug used for Parkinson's disease. And these anticholinergic medications, they cause side effects as well. They can cause dry mouth, blurred vision, constipation, mental confusion, and a lot of times they're not well tolerated in the elderly. So they're typically more effective in your younger patients, probably less than 60 with Parkinson's disease, and they typically have to be used in combination with other Parkinson's drugs. Like I said, these drugs are kind of tricky. The patient usually is therapeutic for the first 3 to 5 years, and then patient will just build up a tolerance to it, and they have to sort of start playing around with their meds. They either have to add a different drug to see if that's effective. Sometimes they'll do a drug holiday. They'll take them off the drugs for about 10 days. And then the patient will just sort of have to kind of bear with having the symptoms of the Parkinson's disease back. And then they'll start adding the medications back on. And what that does is just helps them with the drug tolerance. Supportive patient for a patient with Parkinson's disease is very important. Support for the family is important as well. A lot of disabilities are related, especially with major problems with the gait, the psychosocial problems that occur. Another big problem is the communication. They have difficulty with their speech, eating, and making sure that they have an appropriate diet. Small, frequent meals are typically appropriate. They may have trouble with swallowing, so making sure that they have occupational therapy, physical therapy to assist them. Hopefully, you can keep the patients at home as long as you can with some home assistance. But they're going to need a lot of support. So making sure that they receive this kind of help is very important intervention for a patient. This is just a picture of a common symptom related to Parkinson's disease. It's the mask-like face. Mask-like is related to the rigidity, so they won't be very expressive. They might have that flat affect. They might appear to have that flat affect because of just the mask-like expression, very rigid facial expression. And this relates to their difficulty with their muscles, their pharyngeal muscles, the swallowing and chewing. So, this is something that you might see in a patient with Parkinson's disease. And this concludes part 1 of chapter 44 in module 11.